Hi, let's take another section from the general physiology. We are talking about the cell membrane now, and there are two important subsections in that. One is composition of the cell membrane, and then the transport processes across the cell membrane or through the cell membrane. Now, let me first say at the outset that this topic is uh, quite at the borderline of anatomy and biochemistry as well. I mean, it has got physiology gets overlap with some portion of anat, some portion of biochem, some part of it also comes in patho. So I will take the important concepts which will be required in physiology later on in systemic physiology. I will stick to that part. And why I mentioned it, because sometimes the values differ from subject to subject, from author to author. So let's not forget that. And with that, let's start the first part, and that's composition of the cell membrane. We are going to discuss the constituents and their importance. Now, first thing, the cell membrane in humans, it's a lipid bilayer. Basically, it is made up of a lipid bilayer. That means two rows of lipid molecules, and there are proteins embedded in that lipid bilayer. That's the first basic point. So we have three constituents in the cell membrane: the carbohydrates, the lipids, and the proteins. These three, the carbohydrates, the lipids, and the proteins. How much surface area is occupied by each one of them? Carbohydrates occupy 3% surface area of the cell membrane. Lipids 42%, proteins 50 to 55%. 50 to 55%. There is an approximate range for these values, but that's the proportion of these three constituents. Well, let me just add here. You can see lipids and proteins are the major constituents. By dry weight, lipids and proteins, they exist in a ratio of 1:1. So this is the surface area of the membrane occupied by them, and this is the proportion by weight for lipids and proteins. So with that introduction, now let's see these constituents one by one. The carbohydrates, they occupy 3% surface area of the membrane, and basically carbohydrates offer asymmetry to the membrane. This is not a function. Let me just remind you, this is not a function. This is just an attribute of the carbohydrates, that the cell membrane is, there was a MCQ, the cell membrane is asymmetrical because of which of the following constituents? And the options given are proteins, carbohydrates, phospholipids, triglycerides. So most of the students, they answer as proteins, thinking that the proteins themselves are asymmetrical, and therefore no, it's the carbohydrates which offer, it's because of the carbohydrates that there is asymmetry to the membrane. Carbohydrate moieties are attached asymmetrically on either side of the membrane. So that makes the membrane to appear asymmetrical on the cross-sectional appearance, if you take a section like that. Apart from that, some carbohydrates in the membrane are also involved in immune reactions. Immune reactions of some of the cells are because of the carbohydrates present in their membranes. So that's one. Second, lipids. So there was a question, which of the following is a major lipid in the membrane? Phospholipids, triglycerides, fatty acids, cholesterol. And one more, which of the following, which of the lipid constituents is a fluidity buffer of the membrane? First one, the answer was phospholipids. Second one, the answer is cholesterol. Let's see why. First of all, most important lipid constituent is phospholipids. So maximum concentration is that of phospholipids if we are counting lipids. And I want to tell you something about the phospholipids. So this is just an additional point, okay? It's about the phospholipids that I'm talking about right now, not about the membrane. So I'm writing it separately here. How the phospholipids behave. First point, I mean, when they are in low concentration, if the phospholipids are in low concentration, wherever they are, then at moderate concentrations, how will they behave? And finally, at high concentrations, how will the phospholipids behave? So, and this is relative, okay? At relatively low concentrations, phospholipids will form a single layer of lipids, monolayer. Just they will form one row of lipid molecules. Where do you find this? Example is surfactant. Surfactant is a monolayer of phospholipids and other lipids. Okay. At moderate concentrations, they will form the circular aggregates. They will form the circular aggregates, and by now you might have realized what I am talking about. The circular aggregates of phospholipids. Can you think of something? Yes, bile salt aggregates to form the micelles. You know, for the fat absorption, there is 20 to 40 bile salt molecules. They aggregate. They come together. I'll just draw it here. And they form these circular aggregates. Their tail portions are fat soluble and the water soluble portions are located externally. And at the center, there are fat digestion products, also called as fat digestates. Well, that's not the point. We are talking about phospholipids. So, the next, high concentration. When they are in high concentration, they will form a bilayer. So please remember, at low concentrations, they form single layer, monolayer, and at high concentration, they will form two rows, bilayer. Yeah. So example is our cell membrane. Cell membrane is made up of lipid bilayer. So if we are talking about this cell membrane, there are two rows of lipid molecules. Their hydrophobic tails are pointed inward, as you can see, and the hydrophilic portion. So this is the cell membrane. Now that reminds me of another MCQ which was asked recently. If a microneedle is inserted into a membrane to injure the membrane, let's draw it here. A microneedle was inserted into the membrane to injure this membrane. Healing will occur by what? That was the question. And the options were lateral movement of lipids in the membrane, like this, or lateral movement of proteins in the membrane, like this, and that will cause healing process, or enzymatic interactions, or hydrophobic interactions in the membrane. What's the answer? The answer was hydrophobic interactions. Remember, whenever cell membrane is injured, there are hydrophobic interactions in the cell membrane. See, hydrophobic interactions between adjacent lipid molecules. You can watch this in the diagram. The hydrophobic tails of the adjacent lipid molecules, they will interact like this, and that will result in healing. So this is called as resealing by lipid bilayer. And therefore remember, our cell membranes are self-sealing or spontaneously sealing. So that was about the phospholipids in the membrane. Apart from that, another important constituent is cholesterol. Cholesterol is said to be the fluidity buffer in the membrane. You know, our cell membrane is, its proposed model is fluid mosaic model, which is also called as Singer-Nicolson model. This is the most accepted model of cell membranes, and I've already described it, that there is lipid bilayer and proteins embedded in the lipid bilayer. But it's fluid, and the proteins are embedded in it, giving a mosaic type of appearance. So fluidity buffer means what? Cholesterol concentration will determine whether the membrane is in the fluid state or in a gel state or a solid state. So it's the cholesterol concentration. If the cholesterol concentration is higher, then there would be less fluidity in the membrane. So it's inversely proportional actually, and therefore, however, cholesterol is said to be the fluidity buffer. It's the cholesterol concentration that will decide whether the membrane is fluid or otherwise, I mean gel or solid state. Okay, so that was about the lipids in the membrane, and now the most important part, proteins in the membrane. The proteins in the membrane. This will take a little longer. Now, first thing is protein concentration. I am going to make 2 points. One is protein concentration in the membrane varies from cell to cell. I mean to say membrane to membrane. We have said that it occupies a certain surface area in the membrane, but protein concentration varies. Membrane protein concentration is different in different membranes. There was one MCQ like this. There are 4 options given, and which of them has highest protein concentration in its membrane, right? The MCQ was, highest protein concentration in the membrane is found in which of the following? And the options given were Schwann cell membrane, then presynaptic membrane, adipocyte membrane, or hepatocyte membrane. These were the options given, and highest protein concentration or highest protein to lipid ratio is found in which of the following membranes? Well, the answer was presynaptic membrane, and I'll tell you why. Look, whichever way you look at it, lipid to protein ratio or protein to lipid ratio, the point is, in the membrane, whether it's a high lipid concentration or high protein concentration relative to each other. So, highest lipid concentration is in the Schwann cell membrane, and therefore please remember, Schwann cell, it forms the myelin around the neurons. Therefore you must remember this, myelin is lipid rich. It's very heavy in lipids, and in fact, to remember this, to make you remember this, I will give you an example. So I'll write the example in the bracket. Remember nitrogen narcosis. Remember nitrogen narcosis. What is it? When you are working at high barometric pressures, the high pressure around the body will cause the gases to be dissolved. For instance, a diver who has dived deep into the ocean, and because of the high pressure, high barometric pressure, the gases will dissolve, and the main gas that has been inhaled is the nitrogen. So nitrogen gets dissolved in the body tissues and body fluids. And now the point is, nitrogen has got high affinity for lipids. So what happens is that the nitrogen gets dissolved in the lipids of the body. And I already mentioned myelin, that's the covering of the neurons, is lipid rich. So nitrogen dissolves in the neuronal membranes. Imagine this, that neurons of the brain, nitrogen is getting dissolved there, resulting in the disturbed functioning of the CNS neurons, and that is called as nitrogen narcosis. But the crux of the matter that I wanted you to understand and remember is that myelin sheath is lipid rich because Schwann cell membrane is the, if you compare most of the other cells in the body, Schwann cell membrane has got highest lipid concentration. And to remember that, I gave you the example that nitrogen has got high affinity for lipids, and since myelin is lipid rich, therefore it results, nitrogen dissolves in the neuronal membranes, resulting in nitrogen narcosis. We will discuss about it later in the respiratory system, of course. And then, yeah, so we are talking about the lipids and proteins in the, or lipid protein ratio. So Schwann cell membrane, oligodendrocyte membrane. Yeah, let's make a small correction. Schwann cell myelinates the CNS peripheral neurons, and oligodendrocyte myelinates the CNS neurons. So make a correction over here. Even the oligodendrocytes have 76% almost lipid concentration, and remaining is the proteins. So highest concentration of lipids, almost 76%, is in the oligodendrocyte membrane and Schwann cell membrane. 76% lipids. Yeah, so we have made that correction actually. Schwann cell, peripheral nerves, and oligodendrocytes, the CNS nerves, the brain neurons. But either ways, they are myelinated, and myelin is lipid rich. That's the point. Okay, so highest lipid concentration, and then high protein and low lipid concentration. So now the ratio is reversed, okay? Low lipids and high proteins. The answer is, the most important one is inner mitochondrial membrane. This has the ratio reversed. It contains 76% proteins. That will be easy to remember because all those enzymes in the mitochondrial membrane, they are all proteins. And remember, therefore, highest protein concentration is in the inner mitochondrial membrane. We are talking about all membranes in the body. So, yeah, followed by presynaptic membrane. That's again easy to understand. You know, presynaptic membrane is devoid of any lipid because it is devoid of any myelin sheath. Look, myelin sheath is formed around the neurons, but wherever there is neuronal ending, it's devoid of any myelin sheath, and therefore less of lipid and more of proteins, because there are channels in the presynaptic membrane. And what are those channels? They are protein structures, protein based structures. So presynaptic membrane has got almost 70% composition of proteins. So lipid to protein ratio or protein to lipid ratio, whichever way you want to look at it, remember it that the highest lipid concentration is in the myelin, which is formed by the Schwann cells at the periphery and oligodendrocytes in the brain, in the CNS, and that's high lipid to protein ratio. And high protein to lipid ratio or high protein concentration in the membrane, I've given you important examples like inner mitochondrial membrane, having all those enzymes, or presynaptic membrane having all those channels, but no myelin, so no lipid, or less lipid. Right, so that was the first point that I wanted to mention, proteins and protein to lipid concentration. But the point was, the protein concentration varies from cell to cell or membrane to membrane, and we saw the examples. The other point is, protein concentration for a particular membrane, for a particular cell or for a particular membrane, it varies from time to time. Yes, I mean, the first point was, for any particular membrane, there is a certain protein concentration which we have seen. Like inner mitochondrial membrane has got 76% proteins, or neurons, myelin has got 24% proteins. But it's not that fixed. For a particular membrane, for a particular cell also and its membrane, the protein concentration will change from time to time, because, now that's important, because it depends on the protein turnover rate for that cell. Protein turnover rate. Yes, let me explain this. Here is a typical cell and its membrane. Now, protein turnover rate means here is a membrane protein. We are talking about membrane proteins right now. Here is a membrane protein. It was synthesized inside the cell. It was taken to the membrane. And then when its function was subserved, its function was done, performed, then it will be removed from the membrane. And how is it removed? Look, it will be first tagged. I'm just giving a diagrammatic representation, okay? It will be first tagged. Now, who tags the membrane proteins? The system of enzymes called as ubiquitin. The enzyme is ubiquitin ligase. So, ubiquitin system tags the membrane proteins for their removal. Whenever they have to be removed from the membrane, ubiquitins will tag those membrane proteins. Then they will be removed and degraded inside the cell. They will be degraded, destroyed. Or there is one more question related to this. Membrane proteins are degraded in which cell organelle? Which is this cell organelle where the membrane protein was degraded? Got any idea? Okay, I'll give you the options. Lysosomes, peroxisomes, proteasomes, or Golgi bodies. I'm sure you are thinking lysosomes, but no, it's not lysosomes. The answer is 26S proteasomes. Yeah, that's the cell organelle in which the membrane proteins are degraded. Remember this? So, but the original point was, this is the protein turnover. Synthesis, then coming to the membrane, then after a while, when its job is done, it will be tagged, removed and degraded. So, now it's easy to understand. If the degradation rate is faster than the rate of synthesis, what will happen? Membrane protein concentration will go on decreasing. It will fall. So, you know, even for a particular membrane, its protein concentration of that membrane is not fixed. It can change from time to time. And I have given you the relevant details. Now I'll give you the example of this. A very important example, clinically very important. The example of this is aldosterone and its action of sodium reabsorption from the renal tubules. Sodium reabsorption from the renal tubules. So, you know, sodium reabsorption is a two-step process. Watch this. Here is a renal tubule, and we are currently looking at the lining cells. Here is a sodium, here is the sodium in the lumen, in the tubular fluids. So, sodium reabsorption into the blood vessel. This here is the blood vessel. Sodium reabsorption occurs as a two-step process. Look at this. Sodium from the lumen will first enter the cell lining the tubule, okay, and then it will leave the cell and enter the blood vessel. So it enters the cell through its apical membrane. You know, this side of the cell and its membrane is called as apical membrane, facing the lumen, and the side that is facing the blood vessel is called as the basolateral membrane. So on the apical membrane there is a channel called as ENaC, epithelial sodium channel, or amiloride sensitive channel. Sodium from the lumen will enter the cell via this channel, ENaC. Then on the basolateral side there is sodium potassium pump, sodium potassium ATPase, and you know the function of the sodium potassium pump is it removes the sodium from inside the cell and sends it out. So sodium from within the cell will be pumped out and it will enter the bloodstream finally. So it enters the cell and then leaves the cell on the other side and enters the blood vessel, right? This is how sodium is reabsorbed. Now aldosterone increases the sodium reabsorption. Okay, how? Aldosterone will act on both these proteins. Look, ENaC is a channel and it's a channel protein. It's a protein based structure. Sodium potassium pump also is a protein. So when aldosterone begins to act, it will see to it that these proteins stay for longer duration or their numbers increase. See how? You know, this ENaC, when it has to be removed from the membrane, normally under normal circumstances, when it has to be removed from the membrane, it is tagged by the ubiquitin. You know, we discussed about ubiquitin just now. It's tagged by the ubiquitin, which is called as NED4-like. That's the name of the ubiquitin that will tag the ENaC, and then ENaC will be removed from the membrane and degraded. We have seen that process. What is the role of aldosterone here? Aldosterone deubiquinates the ENaC. This epithelial sodium channel will be deubiquinated. Ubiquitins will be removed so that the ENaC will remain in the membrane. It will not be tagged and it will not be removed from the membrane. Which means what? Which means this ENaC, the epithelial sodium channel, will stay on for longer duration in the membrane and sodium reabsorption will increase. You know what was the point? Aldosterone increases sodium reabsorption. How? By allowing the ENaC to stay for longer duration in the membrane as long as aldosterone is acting, and that will allow the sodium to be moving across the membrane. And of course, aldosterone will also act on the other side of the membrane. Aldosterone will act on the apical membrane. It will allow the ENaC to stay for longer duration. Aldosterone will also act on the sodium potassium pump. It is known to increase the number of sodium potassium pump. Okay, so aldosterone increases the number of sodium potassium pumps. Aldosterone allows the ENaC to stay for longer duration by deubiquinating them. Means ubiquitins are not allowed to tag the ENaC. What is the net result? Net result is these proteins, sodium, potassium, pump and ENaC, their number, their concentration increases in the membrane as long as aldosterone is acting. Yeah. So just giving you the example of how the protein concentration in the membrane changes, varies from time to time, for even for a particular membrane or even for a particular cell, its protein concentration will change from time to time. So that was first point that I wanted to discuss about the proteins in the membrane. The concentration varies from cell to cell, I mean membrane to membrane, and the concentration in a particular membrane also varies from time to time. Okay, now talking about the types of the membrane proteins. Next point is related to the types of the membrane proteins. Basically, there are two types of membrane proteins. One is integral proteins. Integral proteins means they are located within the membrane. Now I am drawing a particular example. Watch it. Here is an integral protein. It's entirely confined or located within the membrane. Can you just guess which this protein is? Yes, it is G protein coupled receptor. G protein coupled receptor is also called as serpentine receptor. Serpentine receptor, because you see how it's located in the membrane, like a snake, like a serpentine position. So serpentine receptor, and remember it has got 7 transmembrane segments. 7 transmembrane segments means it spans the membrane 7 times. Yeah, it spans the membrane 7 times. Now, there's an interesting fact that I wanted to mention here. Very interesting. Have you heard of the term SOS? And how many meanings of SOS that you are aware of? Normally, SOS means save our souls. You know, for a sinking ships, or if the flight is nosediving, the captains, they send SOS messages. Mayday, Mayday, or something like that. But it's called SOS message. Save our souls. Well, in physiology or in medicine rather, SOS means as and when required. You give a tablet and you write the medicine and say take 1 tablet SOS, means 1 tablet as and when required. That's another meaning for SOS. Here, there's another meaning. SOS here means sons of 7. Yeah, sons of 7. Now, what is the connection? Look, this is a GPCR, G protein coupled receptor. Here is a receptor in the cell membrane. So when a particular hormone arrives at the cell and combines with this receptor, this combination will form the intracellular products, the so-called second messengers, like cyclic AMP, cyclic GMP. Now all these are called as sons of 7, kids of 7, because this has 7 transmembrane segments, this receptor. So when hormone combines with this receptor, its intracellular products which are formed, second messengers, they are called as they are called as sons of 7, right? So I gave you the example of integral proteins, and the other type of course is peripheral proteins. Peripheral proteins are attached to the membrane on one side of the membrane. They don't span the membrane, okay? They are attached on one side of the membrane. So many of them are involved in cell-to-cell signaling for adjacent cells. Right. Well, there is one special variety of proteins in the membrane. And there was an MCQ. Now this can come as a case-based question also. Okay, this can come as a clinical question. The question is paroxysmal nocturnal hemoglobinuria. They can give you a case that a patient comes, a small child or 8 to 10 year old, and the complaint is that of anemia and red colored or dark color urine in the night. So what is your diagnosis, probable diagnosis? Paroxysmal nocturnal hemoglobinuria. The MCQ was paroxysmal nocturnal hemoglobinuria occurs from defect of which type of membrane protein? And the options are integral protein, peripheral protein, GPI linked protein, or integrins. The answer is the one which I am about to mention, special category, the GPI linked proteins. There are certain proteins in the membrane which are anchored to the membrane by the GPI linkages. Well, this is just diagrammatic representation to make you understand how they are anchored to the membrane, linked to the membrane by GPI linkages. So, GPI linked proteins in the membrane. The famous example of GPI linked proteins are CD59 and decay accelerating factor, also called as CD55. These are the GPI linked proteins in the red cell membrane, RBC membrane. Remember, RBC membrane has these GPI linked proteins, CD59 and decay accelerating factor, DAF. And what is the function of these proteins? They prevent complement attack on the red cells. They prevent complement attack on the red cells, our own RBCs. They can be under threat from the complement system. So that's prevented by these GPI linked proteins on the red cell membrane. And their defect, if they are defective, a genetic defect or such defect of these proteins results in paroxysmal nocturnal hemoglobinuria. Why? Because simple, if these proteins are defective, then RBCs will come under complement attack by the body's own complement system, and there will be complement induced lysis of the red cells. And if the red cells are lysed in large numbers, then hemoglobin comes out and eventually excreted into the urine. So that's these are the types of membrane proteins. At a very basic level, I wanted to describe the types of membrane proteins. Next part is membrane proteins and junctional complexes formed by the membrane proteins. You know, there are cell-to-cell junctional complexes. This is taught in anatomy, this is taught in dermatology. So I'm only taking the relevant part which we will require in later physiology discussion. Okay, but membrane proteins also form junctional complexes, means the adjacent cells can be linked to each other by these junctional complexes, junctions between the two membranes. Okay, this is particularly so for epithelial cells, but other cells also will show these junctional complexes. So let's see those junctional complexes. Okay, before that, there is an MCQ. It's a clinical based MCQ. The Charcot-Marie tooth disease. Charcot-Marie tooth disease results from, it's a peripheral neuropathy, and it results from the defect of which cell membrane protein or which junctional protein. And the options are desmosomal junctions, or the gap junctions, or tight junctions, or adhering junctions. Well, the answer is gap junctions, and we will see why in some time now. Okay, so let's see the junctional complexes and the membrane proteins involved in the formation of junctional complexes. First type of junctional complex is desmosomes. Desmosomes are also called as macula adherens. Macula adherens. Okay. This is seen like this. This is a basement membrane on which these epithelial cells are based. And you see the adjacent epithelial cells. Their opposing membranes are thickened like a plaque. And this plaque formed by the protein called as desmoplakin. Desmoplakin is spelled like that, although the plaque spelling is Plaque. And then fibrillar proteins extend on either side of on either cell. There is extended fibrillar proteins. So this provides a lot of tensile strength to the entire sheet because of this kind of arrangement. So where do you find these junctions? Where the tissue has a high tensile strength. High tensile strength. So, for example, you can guess it, skin. Skin has got a high tensile strength, and skin cells, epithelial cells, will show the desmosomal junctions. Also, these junctions are found where the wear and tear of the tissue is high. If there is a high wear and tear of the tissue, there the cells are junctioned by desmosomes. So, gums, cervix. Second type of junctional complex is formed. It's called as gap junctions. Gap junctions. Gap junctions are low resistance passages. What do you mean by that? Look, here are two adjacent cells. They are connected by the so-called gap junctions. Not so-called, actually the gap junctions. Right? And low resistance passages means there is free passage of ions, free passage of charges from one cell to the next. Right? So cells are electrically coupled, and therefore the charges flow. And why they are electrically coupled? Because if one cell excites, the other cell excites very quickly, because free flow of charges from one cell to the next. So these are the gap junctions. Right. Now, well, first let's see the example. Where do you find these? Heart. Yes, very prominent example. You must always remember now that the myocardial cells are connected by the gap junctions. And that's one example, prominent. Okay, smooth muscle in the wall of the gut. Smooth muscle in the wall of the GIT. Those smooth muscle cells are connected by the gap junctions. Now, an additional point here. Gap junctions are made up of. They are made up of a protein called as connexon. And so this gap junction is made up of connexon. This is connexon, and each connexon actually is a hexamer of connexins. 6 small subunits of connexins. 6 small subunits of called connexins. So let me give you an example. I asked you Charcot-Marie tooth disease. Yeah, this is a peripheral neuropathy. First point. Why this is a peripheral neuropathy? I mean, what's the basic defect? Defective myelination. And why there is defective myelination? There is a genetic defect in the gene that codes for a connexin. Connexin 32 is defective. Connexin 32 is going to make the gap junctions between adjacent Schwann cells. You know, Schwann cells are going to form the myelin for the peripheral nerves. So, defective connexin 32 results in what? Defective gap junctions between adjacent Schwann cells, and because of that there will be a defective myelination. Defective myelination in the peripheral nerves, peripheral neurons or peripheral nerve fibers, resulting in the peripheral neuropathy. There will be difficult conduction of impulses through the peripheral nerve because myelin is defective. So that's Charcot-Marie tooth disease. Or I may just add one more clinic. So, you know, there's a requirement from the next year about the next exam, and they have given certain pattern that there will be clinical based or problem solving based MCQs. So for physiology nothing changes much. You know, if I am teaching Charcot-Marie tooth disease, I mention it first and then I tell you the defect. The clinical based MCQ will be that they can give you the symptoms of peripheral neuropathy, which is actually a Charcot-Marie tooth disease, and they will ask you what protein is defective. Okay, so you know, basically physiology is such a subject where if your fundamentals are strong like this, if the MCQ gets reversed, you can still answer it. Or if the MCQ becomes complicated, problem solving type, you will still be able to answer that MCQ. One more, idiopathic atrial fibrillation. Another defect, another disease due to the defective gap junctions. Well, this results from defective connexin 40. Defective connexin 40 resulting in defective gap junctions between adjacent myocytes, adjacent atrial myocytes, and that results in the rhythm disturbance, which is called as idiopathic atrial fibrillation. So they may give you atrial fibrillation finding and they will ask you which protein is defective. Yeah, that can be one way of asking problem solving MCQs. So that was the second type of junctional complex, and the membrane proteins involved, the connexins. And the third type of gap junction, which is formed between the adjacent cells, it is tight junctions. Tight junctions are also called as zonula occludens. Zonula occludens. See, tight junctions are selectively permeable. So that's a difference between gap junctions and tight junctions. Gap junctions were freely permeable. These are selectively permeable. Okay. So let's take the example where these are found. Tight junctions are found in the blood-brain barrier, selectively permeable, or epithelial lining of the GI wall. You know, we saw that the smooth muscle in the wall of the GIT, those smooth muscle cells have gap junctions, but the lining has tight junctions, lining of the GI wall. And tight junctions they are selectively permeable. Remember, tight junctions are formed of these three proteins: claudins, occludins, and JAMs. JAMs, JAM, junctional adhesive molecules. So that's a example of tight junctions and what they are made up of. Well, so these are the junctional complexes and the membrane proteins. Look, we have started our discussion on the cell membrane. We discussed there are three constituents: carbohydrates, lipids, and proteins. Right now we are talking about the proteins in the membrane. One part of it was the membrane proteins and the junctional complexes that they form. So we are done with that part. Next is membrane proteins and how they behave as transport proteins in the membrane. So that will be the next section of our discussion. One of the previous sections, we have discussed the cell membrane and its composition. We discussed the carbohydrates, lipids in the cell membrane, and then we've also seen the protein composition of the cell membrane. We described different types of cell membrane proteins. One type that I thought should be discussed here is the transport proteins in the cell membrane. And immediately after that, we will discuss transport processes through the cell membrane so that it would be contextual, that we will be able to correlate the things better. So let's start with the first part of it, the transport proteins in the cell membrane. The proteins that allow the transport of various substances through the cell membrane. At the very basic level, there are four types of transport proteins, and they are pores, channels, carriers, and ATP dependent transport proteins. So at a very basic level, these four are the transport proteins in the membrane. And some of the questions which have come in the past, for instance, which of the following is a ligand gated ion channel? And the options are GABA A, GABA B, muscarinic acetylcholine receptor, or NMDA receptor for glutamate. The answer is of course GABA A. Or some questions like tetrodotoxin is a specific poison for which channel is the question? Sodium channel, potassium channel, calcium channel, chloride channel. Of course, it's a sodium channel. So such questions have been asked from this particular segment. Let us discuss these transport proteins one by one. So first one, pores. Pores in the membrane. They are always open. I mean, if you just have to compare the pores, channels, and carriers, you may compare it like this. Pores are generally always open. Channels are intermittently open, and carriers are never open. They are always in an occluded state. So what are the examples of pores? Pores in the membrane. Aquaporins. You know, ADH, when it goes to the collecting duct, it causes reinsertion of the membrane proteins. Let's say here is a renal tubular section, a collecting duct. The membrane proteins are reinserted in such a way to form the pores. Well, this is just a diagrammatic representation, a simplistic view. So membrane proteins get reinserted to form these pores called as aquaporins, and once they are formed, there will be a continuous water reabsorption from the collecting duct. So aquaporins, which are synthesized under the influence of ADH, they are the examples of pores. Or perforins, another example of pores. You know, cytotoxic T cells, they punch holes in the bacterial cell wall. There is insertion of these perforins through which the water enters the bacterial cell and eventually it will be destroyed. So these are the examples of pores. Second type of transport protein is channels. Channels in the membrane. Channels are involved in simple diffusion. First point. Simple diffusion of what? Simple diffusion of water soluble substances. Ions, sodium ions, potassium ions, calcium ions, etc. So, you know, the cell membrane is made up of lipid bilayer. There are two rows of lipid molecules, and embedded in the lipid bilayer are these protein channels. Lipid soluble substances, their simple diffusion will occur through the lipid bilayer, but water soluble substances which are not lipid soluble, they have these specialized channels in the membrane. So we are looking at these channels involved in simple diffusion of water soluble substances. Second point, what are the various types of channels? Let's see the types of channels. Well, at a very basic level, there are two types of channels. One, leaky channels. You know, leaky channels are somewhat similar to pores. They will allow a continuous leakage of that particular substance. For example, sodium leaky channels. In the membrane of all the cells, there are sodium leaky channels, and they allow a continuous leakage of sodium ions into the cell. So, if you just recall, we have done this in the first segment, that there are proteins inside all the cells, and proteins are anions. So, equal number of cations should also be pulled into the cells, and that cation is of course the sodium, and therefore remember we have mentioned this in the previous section that sodium is leaking into all the cells of the body continuously. Why? So of course there is a law of electroneutrality, the equilibrium has to be reached, and therefore sodium is continuously leaking into all the cells through these leaky sodium channels. Okay, well, it does not stay there. What happens to this sodium, we will see that later, but this has to be kept in mind that sodium is continuously leaking into all the cells of the body through the leaky channels. Well, the other type of channels, gated channels, means they have got gates, and those gates open or close. Only when the gates are opened, the movement of that particular ion is possible. So that's the gated channels. Now, based on the gating behavior, there are different types of gated channels. Let's see those gated channels. First, voltage gated channels, meaning that these channels have got gates, and those gates will open or close according to the voltage change of the membrane. So voltage is deciding factor whether the gates will be opened or closed. Example, sodium channels in the nerve membrane, voltage gated fast sodium channels in the membranes of the nerves, which are responsible for depolarization of the nerves. These are voltage gated. They can open at a voltage of minus 70 millivolts, but they cannot remain open in a positive voltage. So these are voltage gated channels. One more category which has been recently discovered, they are called as NAVs, sodium and voltage. So another sodium channels, for instance, NAV 1.8, it's a voltage gated channel. It's present in the pain pathways, primary afferents of the pain coming from the skin and entering the spinal cord, where they synapse to the second order neuron. Those neurons in the pain pathway have these NAV 1.8, sodium voltage gated. So voltage gated sodium channel. These are also called as tetrodotoxin resistant sodium channels. That means these sodium channels, they are resistant to even the action of tetrodotoxin, which is a specific poison for sodium channels, which we will see in the due course of our discussion. However, that's the first type of channel. Second, ligand gated channels. That means a ligand will arrive at the cell, it will combine with the receptor portion, and then the channel will open. It's something like this. Let's say here is an entire protein. So one portion is for the ligand binding. Say acetylcholine is that ligand. It is released in the neuromuscular junction. It combines with the receptor portion, and then the gates of the channel will be thrown open. So this is a ligand gated ion channel. Examples, GABA A, nicotinic acetylcholine receptor. Nicotinic acetylcholine receptor is present in, and the associated channel, of course, receptor portion and the associated channel. So this is present in the neuromuscular junction, it's present in the ganglia, autonomic ganglia, and it's present in the CNS. If these are ligand gated channels, then what is GABA subtype B or muscarinic acetylcholine receptor? Aren't they ligand gated? Well, they are categorized into the next type. Those are called as cyclic nucleotide gated channels. Cyclic nucleotide gated channels. So just to compare, okay, nicotinic receptor versus muscarinic, which we will see just now, the CNG. The ligand gated channels have been called as ionotropic receptor associated channel. It has a very simple and fast mechanism that the ligand combines with the receptor, and the channel opens and the ion movement will occur. Very straight, fast and simple. Then what is this CNG? The muscarinic acetylcholine receptor or GABA subtype B. It's cyclic nucleotide gated. Cyclic nucleotide means cyclic AMP, cyclic GMP. So these are cyclic AMP gated channels or cyclic GMP gated channels. Or they are also called as metabotropic receptor associated channel. So receptors are different and therefore the mechanism is different. Metabotropic receptor associated channel. We can also call it GPCR associated channel, G protein coupled receptor associated channel. So how does this work? There is a G protein in the membrane, and certain ligand arrives and combines with the G protein associated receptor. Okay, here is a receptor and here is a G protein. So G protein coupled receptor. Ligand comes and combines with this receptor. The G protein has alpha subunit, alpha, beta, gamma. It's a heterotrimeric G protein. Alpha subunit will dissociate from the other two subunits, beta and gamma, and it moves along the membrane and will activate an effector protein inside the cell called as adenylyl cyclase enzyme. So adenylyl cyclase enzyme that will convert the cellular ATP into cyclic AMP, and then this cyclic AMP will then open the gates of the channel. So cyclic AMP gated channel, or guanylyl cyclase enzyme will be activated. So GTP will be converted into cyclic GMP, and that cyclic GMP will open the gates of the channel. So cyclic GMP gated channel seen in the retina, in the rods, or cyclic AMP gated channels seen in the heart or at some other places. Right. So that's cyclic nucleotide gated channel, metabotropic receptor associated channel. Why it's called metabotropic? Because metabolic machinery of the cell is getting activated. Unlike the previous one where just a simple opening mechanism and ionic flux happens. Right. What are the examples? Well, some examples we've already seen. GABA subtype B, muscarinic acetylcholine receptor. So please remember, nicotinic acetylcholine receptor is the ligand gated channel or ionotropic receptor associated channel, whereas muscarinic receptor of the acetylcholine and the associated channel is called as cyclic nucleotide gated channel, or GPCR associated channel. It can be called G protein coupled receptor associated channel, or metabotropic receptor associated channel. One name that should be mentioned here is HCN channel. HCN channel in the heart, particularly in the SA node. This channel is contributing to the pacemaker current in the heart. Look, this is called as hyperpolarization activated cyclic nucleotide gated. It is a sodium channel, and it has been sometimes called as a funny channel, or the current of sodium happening through it has been described as a funny current. Why? Because normally hyperpolarization will temporarily inhibit a sodium channel. But this channel, when the research workers found that this is a unique channel, in that more the hyperpolarization of the membrane, more is the activation of this channel, this sodium channel. That was funny when they discovered it. So they also called it funny channel. However, it's hyperpolarization activated cyclic nucleotide gated sodium channel. That's one category of the channels rather. Then next is time gated channels. Time gated channels are the ones which for which time is of essence. Time is important for them. Example: potassium channels in the nerve membranes, or slow calcium channels in the heart responsible for the plateau in the action potentials. So time is the deciding factor. Time is the governing factor for opening and closure of the gates. For example, potassium channels, they are said to be lazy channels. So you see, Some channels are funny channels, some channels are lazy channels. Potassium channels are lazy, they are slow to open, they are slow to close. Right? They take certain time to open, they take certain time to close. That's a time gating. Right. The fifth type of channel is mechanically gated channels. Mechanically gated channels means a mechanical stimulus will open the gates of those channels. What is the example? Touch receptor in the skin. It's a mechanically gated sodium channel. When you apply touch is a mechanical form of energy, and that opens the sodium channel. So it would be called as mechanically gated sodium channel. Touch receptor in the skin is just an example, but there are many mechanical types of stimuli and they open respective channels. Right, so these are the main types of the sodium channels. Now, I'm going to discuss one special type separately. So I'm making a square to describe it separately. Chemically gated channels. You would be surprised and you will ask, why am I putting it separately? Ligand gated channels are chemically gated channels. So why I am putting these separately? The reason is, when I say ligand gated channels, the ligand arrives at a cell from its extracellular side. Ligand arrives at a cell from a distance. And when I say chemically gated channels, I am talking about the intracellular chemical which can open or close the gates. Right? So let that distinction be made. Here I am talking about the intracellular chemical mainly. Right. So what are these channels? O2 sensitive potassium channel and ATP sensitive potassium channel. I would like to put these channels as chemically gated channels. Later on, we will also describe once again the ATP sensitive potassium channel as a discussion of ATP dependent transport proteins. Once again, we will discuss this. So, these two are the chemically gated. Now, just to understand these channels, I am taking an example. Hypoxia causes vasodilation everywhere in the entire circulation, but it causes vasoconstriction in the pulmonary circulation. So, same hypoxia, same stimulus, it causes vasodilation in all the vessels, systemic vessels, except in the lungs where it causes vasoconstriction. Why is that? It's because of the channels. In the blood vessels, there are smooth muscle cells that line the blood vessel walls. Here is a blood vessel shown, its cross-sectional view, and the smooth muscle cells have been shown that are lining up the wall of the blood vessel. In the membrane of these smooth muscle cells, we are looking at the channels. So, in the membrane of the smooth muscle cell that lines the blood vessel, so I am calling it VSMC, vascular smooth muscle cell. In the case of systemic blood vessels, where hypoxia leads to vasodilation, the vascular smooth muscle cell consists of a channel called as ATP sensitive potassium channel. And in the pulmonary circulation, in the lungs, those blood vessels, or rather that VSMC, vascular smooth muscle cell, its membrane contains O2 sensitive potassium channel, which leads to vasoconstriction in the pulmonary circulation. Let's understand why it happens like this. Let's consider the lungs. Now, in the lungs, this blood vessel and the channel that we are discussing is O2 sensitive potassium channel. So I'm just enlarging this smooth muscle cell. Enlarged view of the smooth muscle cell. Here it is. Its membrane contains this O2 sensitive potassium channel. Now imagine that there is hypoxia in this region. This hypoxia is sensed by this channel, and the channel will close. This is a O2 sensitive potassium channel or hypoxia sensitive potassium channel. It senses the hypoxia and it closes. What is the result? The potassium that was expected to leave the cell will not be able to leave the cell. Which means what? Potassium from the core of the cell, it will just come near the membrane. It will accumulate near the membrane, on the inside of the membrane. Which means what? Which means the membrane is depolarized. Which means what? This cell will contract. The smooth muscle cell will contract. The smooth muscle fiber will contract. Which means what? There will be vasoconstriction. You know, vasoconstriction happens when the smooth muscle cells will contract. Here is the reason why smooth muscle will contract, because of the hypoxia in the case of lungs. So just a quick revision. If there is a hypoxia in the lungs, the O2 sensitive potassium channel or hypoxia sensitive potassium channel will close. Potassium cannot go out now. So potassium will accumulate inside the membrane. The cell will depolarize because of that, and the contraction of the cell will cause vasoconstriction. The other type is ATP sensitive potassium channel. So what happens in the systemic blood vessels? Let's say here is a systemic blood vessel, and in this region there is hypoxia. Again, in the wall of the blood vessel there are these smooth muscle cells, and the smooth muscle cell, its membrane has ATP sensitive potassium channel. So I'm just enlarging this one cell, one smooth muscle cell, and here is a channel in its membrane. So what happens is, if there is hypoxia, now this is the systemic blood vessel, okay, this is some tissue in the body, some organ. Hypoxia leads to lack of ATP. If there is no oxygen, there is no ATP generation in the region, and because of the lack of ATP, look, this channel was going to sense the ATP and it was going to close. I'm talking about the ATP sensitive potassium channel in the systemic blood vessels. It senses the ATP inside the cell and it closes. Now there is hypoxia. If there is hypoxia, ATP generation is less, and lack of ATP means the channel cannot close. The channel remains open. By sensing the ATP, it was going to close. Lack of ATP, it remains open. If the channel remains open, that means remember, it's a potassium channel. So intracellular potassium now leaks out. If the potassium leaks out, means what? Positive charges are leaking out of the cell. Positive charges leaking out means what? Inside becomes excessively negative. Inside of the membrane becomes excessively negative. the cell is hyperpolarized and therefore it cannot contract, it will relax. This is a smooth muscle cell. It relaxes means what? The blood vessel will dilate. Quite easy to understand. We are talking about the vascular smooth muscle cell. If it relaxes, the blood vessel will dilate. So that's the reason why systemic blood vessel will dilate, but pulmonary blood vessel will constrict because of the hypoxia. So the reason is there are two different channels in these two different vessels. This was a chemically gated channels. Well, let me just add one more example of ATP sensitive potassium channel, because this will be discussed even later on and it's required in the pharmacology as well. One more place where we have ATP sensitive potassium channel, and that is pancreatic beta cell. We are talking about secretion of insulin. This cell, its membrane contains this ATP sensitive potassium channel. Here is that ATP sensitive potassium channel. So the question is, how is it that in response to the increased blood glucose, insulin is released? Insulin gets released by the pancreatic beta cell. The mechanism goes something like this. Here is the blood glucose. We are showing the pancreatic beta cell. So blood glucose, increased blood glucose, it enters the pancreatic beta cell. It undergoes glycolysis. Glycolysis will generate the ATPs. And sensing these ATPs, the ATP sensitive potassium channel will close. Now it should be clear to you that when there are ATPs generated inside the cell, the ATP sensitive potassium channel closes. And if there is hypoxia and no ATP generation, then the channel remains open. It cannot close. No ATP, no closure of the channel. ATP generated, channel closes. So ATP sensitive potassium channel closes, which means what? Which means potassium cannot go out. Potassium starts accumulating inside the membrane. It means what? It means the membrane has begun to depolarize. Positive charges are lining up inside the membrane. Membrane depolarization is happening. This is a voltage change for the membrane, and that opens voltage gated calcium channels. VGCC, voltage gated calcium channels open, sensing this voltage change. The calcium from the ECF will enter, and finally, because of this calcium, this insulin which was stored in these granules will be secreted by exocytosis. By exocytosis, the insulin will be secreted. So that's how insulin gets secreted. For insulin secretion, the calcium inside the cell has to increase, and for that to happen, this channel is very, very important. ATP sensitive potassium channel. In fact, remember, there's a category of drugs called as SURs, or rather sulfonylureas. Actually, the drug name is sulfonylurea, the category, and the sulfonylurea has got a receptor, sulfonylurea receptor, which is associated with this ATP sensitive potassium channel. So when this drug is given, this drug is called as insulin secretagogue. It's going to cause secretion of insulin. The drug will bind with this receptor, sulfonylurea receptor, that will close the potassium channel, and the subsequent events, they will follow. Right. So these were the chemically gated channels. That was in a nutshell the various types of channels. Now I want to discuss two more things related to the channels. How are the channels studied? And what are the poisons or blockers of the channels? Poisons or blockers of the channel. So first thing, there was actually an MCQ a few years ago. The ionic flux through a single ion channel is studied by what method? And the options given were patch clamp technique, voltage clamp technique, a pair of microelectrodes, or cathode ray oscilloscope. So please remember, patch clamp technique or patch clamp method is the method that is used. Patch clamp technique or method is used for study of a single ion channel and the currents that are going through a single ion channel. Voltage clamp technique is used to study the voltage changes across a membrane, and cathode ray oscilloscope is the instrument that records the action potential from a nerve. Right. The second point related to the channel which I wanted to discuss is what are the poisons or blockers of the channels. Right. So voltage gated sodium channels have these poisons. Tetrodotoxin is a very specific poison for voltage gated sodium channels. It's commonly called as fugu poison or nerve gas poison, something like that. You know, tetrodotoxin is found in a variety of fish called as puffer fish, and some delicacies are also made from that puffer fish, but it's a very strong nerve poison, because when the tetrodotoxin is given, within several minutes there is going to be blockade of voltage gated sodium channels in the nerve membranes, which means there would not be generation of action potentials possible. So no impulse propagation through the nerves, and therefore it's a very strong nerve poison. No signaling through the nerves means there is hardly any chance of the survival of the patient, of the person. So tetrodotoxin, another similar poison which is also found in another fish, saxitoxin. These are the sodium channels. Then potassium channels. Potassium channels are poisoned by TEA. That's not the tea. Many people consider our tea also, tea, coffee, as also poisonous. Forget that. Apart from that, this tea is tetraethyl ammonium. Tetraethyl ammonium. Then mamba snake venom. This also contains a component that blocks the potassium channels. That was a summary of the channels and their studies and their poisons. So we are discussing transport proteins in the cell membrane. First we saw pores, then we discussed channels. Now the third one is carriers. Carriers are involved in two types of transports. Carriers carry out facilitated diffusion and carriers carry out secondary active transport. So these two transport processes, we are going to discuss transport processes after this, so a correlation can be established. But for now you can remember facilitated diffusion and secondary active transports are carrier mediated transports. And in the facilitated diffusion, only a single substance is transported, one substance transported by that carrier. And therefore, in that scenario, the carrier is called as uniporter and the transport of that substance is called as uniport. single substance transported, so uni. Whereas secondary active transport is the transport in which two substances are transported by the carrier simultaneously. Okay, two substances. When those two substances are going in the same direction, they are carried in the same direction by the carrier, it is called as symport or co-transport. And if those two substances are going opposite to each other, then it will be called as antiport or counter transport. So that's the carrier mediated transport: uniport, symport, antiport. Let's now see the example. And the example is glucose. Glucose transport into all cells, almost all cells of the body, is by facilitated diffusion. And actually we are talking about the transport proteins. So the transport protein is GLUT or GLUT as it's called. So glucose enters the cells of the body generally by using this carrier called as GLUT. Except in GIT and kidney. Except at these two places where glucose enters the cell by secondary active transport, which is called as SGLT, sodium glucose transport. Now the question is, why is it that in all the places of the body glucose enters the cell by facilitated diffusion, and only in the GIT and kidney it is by secondary active transport, it is using some other carrier? Why is it like that? The answer is simple. In the case of all other cells of the body, when glucose is entering the cell from the blood, it is entering the cell, it is going high to low concentration, and therefore it's going to be a diffusion, facilitated diffusion I mean to say. So it will use GLUTs. GLUTs are the carriers for facilitated diffusion, and glucose is going high to low in all other cells of the body. So it's going high to low, it will use GLUTs, facilitated diffusion. But in the GIT and kidney, but remember, glucose here, let me just come back for a while. In this case, wherever glucose is entering the cells, it has to cross only one membrane. See, it crossed only one membrane and entered the cell, and then it's going to be metabolized by the cell, right? So it's going to be always high to low for such cells. In the case of GIT and kidney, the matter is slightly different. See, in the case of GIT and kidney, glucose movement is happening for the sake of absorption or reabsorption. If it's a digestive tract, we call it absorption of glucose. If it's a kidney, then we call it reabsorption of glucose. However, it is happening like this. Glucose is in the lumen of the GIT or kidney, and it is going to be absorbed into the bloodstream. So let's show a blood vessel over here. Here is a blood vessel, and glucose from the lumen is going to enter the bloodstream, means it will need to cross two membranes. Look, in the case of all other cells of the body, glucose from the blood enters the cell and it will be metabolized by the cell, energy production. In the case of GIT and kidney, glucose is meant to be absorbed into the bloodstream. So it has to cross the cell. That means it has to cross two membranes of that cell. See, you can see in the diagram. So from the lumen, the glucose enters the cell, and then from the other side it leaves the cell and enters the blood vessel. So the membrane which is facing the lumen is called as apical membrane, and the membrane that is facing the blood vessel is called as basolateral membrane. So apical membrane, where glucose is entering the cell, it is going low to high. When from the lumen it enters the cell, it's actually going low to high. And then from the cell, it goes out and enters the blood vessel, it is going high to low. First thing first. Because most of you think that if it has to enter the cell, it always has to be high to low concentration. No, that's true everywhere else. In GIT and kidney, the matter is different because it is crossing two membranes, one after the other. So what's happening is that the transport protein which is present on the basolateral membrane is relatively slower, and therefore what happens is the glucose goes on accumulating inside the cell. This transporter is little slower, so the glucose concentration inside the cell becomes high. So low to high to enter the cell, and high to low to leave the cell and enter the blood vessel. So low to high, when glucose is entering the cell, it uses SGLT, secondary active transporter, and the carrier is called as SGLT, sodium glucose transporter. And high to low, when glucose leaves the cell, it's facilitated diffusion, so it will use GLUT, this transport protein. This carrier protein will be GLUT. Just remember one more fact here. GLUT has various types. GLUT 1, 2, 3, 4, 5 and so on. Particularly in GIT and kidney, or let's say whenever glucose has to leave the cell, it always uses GLUT2. Please remember, here the glucose is leaving the cell and going into the blood vessel, it will use GLUT2. Or glycogenolysis. You know, glycogen, the polymer of glucose, is stored in the liver, in the muscle. So when glycogen breakdown happens, glucose is formed inside the cell. Now this glucose has to come into the blood vessel to increase the blood glucose levels. How will the glucose from the cell come out and come into the blood vessel? By using GLUT2. What I'm trying to say is, whenever glucose has to come out of the cell, it always uses GLUT2. Remember this. Right. But the point that we were discussing is about the transport proteins in the membrane. We have discussed pores, we have discussed channels, we have discussed carriers. Carriers are uniport, symport, antiport, and they are involved in facilitated diffusion and secondary active transport. The next category of transport proteins is called as ATP dependent transport proteins. ATP dependent transporters. And in this, there are two varieties, there are two types. One is ATPases, also called as pumps. These are involved in primary active transport. They carry out primary active transport, these ATPases or pumps. Example, our famous one, sodium potassium pump. It's present in the membrane of all cells of the body. So sodium potassium ATPase is a primary active transport, and it's called as ATPase. The other one is the other subtype of this ATP dependent transport proteins. It's called as ABC transporters. ABC transporters means ATP binding cassette transporters. My first point is, what is the difference between the two? The similarity is known that both of them are going to use and break down the ATPs. They are going to use ATP. That's certain. So both will use ATP. In the case of primary active transport, the sodium potassium pump, there is a single part where ATP will get bound and the ions will get bound, sodium and potassium, and then the transport of ions will happen. So it's structurally a single part where of course subunits will be different, but a part where ions and ATPs will be bound. After ATP bound, ATP broken, and then sodium and potassium will be transported. In the case of ABC transporters, ATP binding cassette transporters, the mechanism is slightly different. It has one part where ATP will be bound and that ATP will be utilized for the other part of that protein to be operative. That other part could be a channel or a carrier. Okay, so one part, it's like a cassette, cassette has A side, B side, something like that. One part has ATP binding domain, and once that happens, the other part will act like a channel or a carrier. We have seen one channel like that, ATP sensitive potassium channel, Well, so these are ATP binding cassette transporters. What are the examples? The ATP binding cassette transporters are P glycoproteins. Especially the famous examples are CFTR, cystic fibrosis transmembrane regulator. It's a chloride channel, but it's a ATP dependent chloride channel. Or SUR, sulfonylurea receptor. That's a potassium channel, but it's a ATP dependent potassium channel. So a channel is for the diffusion, we know that. And diffusion is a passive transport, it does not need ATP's energy. But these channels are different, they do need ATP. So that's why I have placed them again as ATP dependent transport proteins. One more, MDR, multi-drug resistant transporter. These transporters are expressed, this is a P glycoprotein. This transporter is expressed by the cancer cells. Cancer cells, they become resistant to the action of the anti-cancer drugs. How? By expressing the MDR transporter in the membrane. And what happens is, suppose the drug was given, it entered the cell, and then MDR transporter causes the drug to be extruded out of the cell. So that means this anti-cancer drug will never reach a critical concentration inside the cell, and the cell will become resistant to the action of this drug. Or XDR cases of tuberculosis, extremely drug resistant tuberculosis. We see that the person who is resistant to a particular anti-TB drug is resistant to all the drugs in that category. Why? That's because of the expression of MDR transporters in the membranes of those cells. So these are the transport proteins in summary. Before we close this particular section, I'll give you an easy way of remembering the structural significances, or how will you remember the structural characteristics of the proteins. Let's write like this: 7, 6, 5, 4, 3, 2. 7. GPCR, G protein coupled receptor, has 7 transmembrane segments, spans the membrane 7 times. Remember, we have discussed it previously. And it's also called as serpentine receptor. So 7 transmembrane segments. 6. Remember, connexon that forms the gap junctions between the cells. It is made up of 6 subunits of connexins. So connexon is a hexamer which is made up of 6 connexin subunits. 5. Ligand gated channels are pentameric proteins with 5 subunits. Okay, so GABA A, nicotinic acetylcholine receptor, these are all pentameric proteins with 5 subunits. By the way, their receptors are also called as cis loop receptor. Just an additional information. The receptor which is associated with the channel is that receptor sometimes called as cis loop receptor. 2 cysteine residues linked by a disulfide bond making a loop. So cis loop receptor. Okay. 4. Voltage gated channels. They are tetrameric proteins, tetramers. 3. Okay. ENaC, epithelial sodium channel, is a trimeric protein. It has got 3 subunits, alpha, beta, gamma. Then G protein. Look, there is a G protein coupled receptor. That receptor has 7 transmembrane segments, but G protein itself has 3 subunits, alpha, beta, gamma. Sodium potassium pump is a trimeric protein. Now that's debatable, because I am sure most of you have read the authors which have said sodium potassium pump has 2 subunits, alpha and beta. But recently another subunit has been discovered for sodium potassium pump, and that's gamma subunit. And gamma subunit has been said to be belonging to the category of proteins which are called as FXYD proteins. So sodium potassium pump is a trimer. It has got 3 subunits, alpha, beta and gamma. Gamma subunit discovered recently, and the gamma subunit belongs to the category of proteins called as FXYD proteins. So I know it becomes debatable whenever I mention this, because most of you have read sodium potassium pump is it has got 2 subunits. The 3rd subunit has been discovered recently. Then 2 subunits. There are lots of proteins with 2 subunits, or like a insulin receptor, alpha, beta subunits, or integrins in the cell membrane. Integrins are the proteins which are dimers. Actually, cellularly they will show 2 units, 2 subunits. So they are dimers, right? So these were the transport proteins in the cell membrane, and therefore now we can discuss the transport processes through the cell membrane.